well get started in the interests of time.
Perfect. Yeah.
So it's Derek Smith here. I am very privileged today to have the opportunity, thanks to some help from our friends from UCB, to introduce Dr. Derek Debicki, who is a wonderful neurologist from down the road in London, Ontario. He's an MD PhD, did his training at Western, and specializes really in neurology as it pertains to critical illness neurology, and also in epilepsy. And he's an electroencephalographer, and so is uniquely positioned to give us a bit of insight into approaching the management of seizures in hospital patients, and in particular ICU patients. So, and above all, he's a Derek, which is great. So I'll let you take it away.
Thank you so much. I'm very happy to be here, and thank you very much for the invitation. It's a privilege to be able to just talk about management of seizures in the hospital and the ICU with you today. I recognize that there's a bit of a diverse group here from different areas of the hospital, so we'll try to touch on each of those things, and hopefully the information that we'll be able to relay today will be helpful in all of your practices in different ways. So just my disclosures: I've had speaking interests with Synovian and UCB in the past, and this program is supported with UCB as mentioned. So today I'd like to kind of talk about seizures in the hospital, monitoring seizures in the hospital and the ICU, and how to treat those. And if we have time, I'd like to discuss North syndrome as well. I'm just not sure if we're going to be able to have that time, but we'll be able to see if there is some particular interest. We can answer some questions about that as well. So first, starting with seizures and epilepsy and status epilepticus in the hospital and the ICU setting. I think that if we think about how do we use anti-seizure medications in the ICU or in the hospital itself, then we think about it in different ways. First of all, it is about acute therapy. So whether seizures are the presenting concern, or whether there's seizures are a complication of illness in the hospital, or we're treating status epilepticus, we'll be using anti-seizure medications. We can also, in some cases, think about use of anti-seizure medications prophylactically in certain vulnerable patients. And then also we would think about using it for patients who are already known to have epilepsy, who come into the hospital for whatever reason it might be. We need to be able to continue and maintain the management of the chronic epilepsy, as well as manage any breakthrough seizures that might be in part related to their acute illness, but related back to their chronic epilepsy as well. So just touching on a few of those things and maybe working backwards is management of chronic epilepsy in the hospital. Of course, we want to make sure that we're continuing to maintain the management strategies that patients might already have when they come into the hospital, but we have to pay attention to things such as route of administration. And so, for example, if patients are on oral medications and they're coming to hospital and suddenly can't swallow or can't get an NG2 for some reason, there might be a transient need for IV therapy. So there are some medications where we can switch very quickly from oral routes to intravenous routes, but there might be other medications where we might have to change a medication transiently. Also, we need to consider drug-drug interactions, in which case transiently we might have to change medications, whether it's because of a use of an antibiotic or use of other types of medications, and that might be transient or that might be more permanent, depending on the situation. And then I think we just have to know that sometimes there may be changes in metabolism or how the elimination with systemic illness and how that might affect our drug levels that might have otherwise been stable prior to coming into the hospital. We also have to manage any breakthrough seizures. These could be provoked or unprovoked. And in some cases, they just might be transient. And as soon as patients get over their acute illness, they can go back to their typical strategy. Or sometimes there needs to be a permanent change in medication adjustments depending on how patients present to the hospital. And I think it's also important to know what the baseline epilepsy characteristics is so that we can manage our expectations. And so if we know what their baseline seizure frequency or what their baseline seizure patterns are, we can see if this is a new situation for the patient. Is there a sudden increase in the frequency that they usually have, or is there a new pattern of seizures? But if someone is prone to having multiple seizures per day and are in the hospital, then we can't expect to make sure that they're seizure-free before sending them home or before kind of, for example, extubating them or getting them off of sedating medications in the ICU. And that goes the same for baseline EEG findings. We need to, it's always helpful to know what EEGs look like because we might not be able to get them back to a normal EEG versus getting them back to what the EEG looked like before coming into the hospital. In terms of prophylactic use of anti-seizure medications, there aren't that many groups that we do this for, and probably traumatic brain injury is the group that we would think about prophylactic medications. Classically, we use phenytoin for 7 days to prevent early, but not necessarily late seizures. There's been lots of discussions around the use of levetiracetam over phenytoin. And considering whether that could be a reasonable alternative to phenytoin in situations. In terms of subarachnoid hemorrhage, that might be a group that where there's still many questions that remain. There hasn't been strong evidence to support its use as a seizure prophylaxis, but there might be, there's ongoing thoughts around that. Same thing with intracerebral tumors. This has been assessed before, and there's no indication for that, and noting that there can be drug-drug interactions with some chemotherapeutic agents with some of our anti-seizure medications. And finally, in stroke and intracerebral hemorrhage, there's been a number of practice guidelines, particularly through the Canadian Stroke Best Practice guidelines, that prophylactic use has not been recommended in terms of trying to prevent seizures. So traumatic brain injuries remains the main group that we would think about prophylactic use for. And then finally getting to, really what we wanted to talk about today is how do we treat seizures in the hospital and in the ICU setting. There are many patients that can have seizures in the ICU or in the hospital in general, particularly with patients who present with neurologic dysfunction. And so we can take a look at some of the numbers around what is the likelihood of finding a seizure when patients present with certain conditions. So for example, following convulsive status epilepticus, up to 50% of patients will likely have ongoing seizures if we record with EEG monitoring. And that might be the same for, or maybe not that high, but we can see upwards of 25 to 30% in a lot of the different conditions. So for example, intraparenchymal hemorrhage or moderate to severe traumatic brain injury. So we can see a fairly high percentage of patients who can have seizures. Now, this is also associated with looking for seizures with EEG monitoring. And in many instances, this involves continuous EEG monitoring. And so one of the thoughts are that we need to be mindful that these conditions, there's a high likelihood that patients may have either non-convulsive seizures or some changes in the EEG patterns that might influence your management. And so this is one thought of and advocating for looking for seizures in the hospital and in the intensive care unit with EEG or continuous EEG monitoring. How long would we have to look to find those seizures if we were to monitor with continuous EEG monitoring? Then, at the start of a continuous EEG, you would only capture about 15% of seizures. But by the time we get up to about 48 hours, we've captured about 93% of seizures if they were going to happen. And if we go up to 72 hours, then we're even increasing that further. So that is the time frame in which a lot of people, if they're going to be able to establish a continuous EEG monitoring program, that would be the time frame in which we would be monitoring in those suspected patients that might be at risk of having non-convulsive seizures, or even convulsive seizures for that matter. We can sometimes use screening and a first hour of screening to be able to make better predictions as to how long we would need to record patients to capture seizures on EEG. This is the 2 helps 2B score, which has been kind of validated and really looking at certain features, whether they're clinical features such as previous history of seizure, or whether they're EEG features that that you're looking for on the first 60 minutes of continuous EEG monitoring. So if they're greater than 2 Hertz frequencies, so fairly fast abnormal activity, epileptiform discharges, whether you see specific lateralized patterns, plus features are just extra little things that are happening in relationship to that EEG, or specific things called birds, which are just really quick rhythmic discharges. Those might predict seizures, and we can see that with a score of more than 2, then the predicted risk of seizure is more than 25%, and would recommend a longer assessment of continuous EEG. I see that there's a question, Dr. Smith. I think you have your hand up, and there might be something in the chat.
Yeah, I was just going to draw your attention to the fact that in the chat, Dr. Finkelstein had asked about on that slide for prophylactic use. He was asking about specifically post cardiac arrest.
Yep.
And then I just wanted to clarify that the subarachnoid on there was like aneurysmal subarachnoid hemorrhage.
Yes.
Yeah.
Thank you. And sorry, let me just see if I can pull down the chat. Is there a role for prophylactic use of AEDs? No, not at the current time. There is no role for prophylactic use of AEDs. And depending on availability, there are some centers that will do more EEG monitoring during those times, particularly during targeted temperature management to look for evidence of seizure. But often if you, in that phase of time where you're either sedating patients or completing a targeted temperature management protocol, then you're looking for features such as myoclonic status epilepticus, but no role for prophylactic use. Okay, so maybe just taking a look at what are the different types of seizures that we might encounter in the hospital. We see convulsive seizures, and those are probably the most common ones that we would see because they're observable, and we're told about them by staff and by families. If we see convulsive seizures, we can also see non-convulsive seizures, and those are discrete seizures that we talk about. And then we can get into convulsive status epilepticus and non-convulsive status epilepticus. So we'll touch on those in particular. And as we all know, then convulsive status epilepticus is a neurologic emergency. And so we'll concentrate on that a little bit because it would have implications both in the emergency department, on the ward, and in the ICU. There are specific definitions of status epilepticus. And so, for example, there are 2 time points that have been identified that are quite meaningful in the treatment of status epilepticus. The first time point is thought to be 5 minutes, which is beyond which seizures are likely to be prolonged, or beyond which seizures are unlikely to stop on their own. And so often we'll write orders to say give some benzodiazepines if seizure is lasting more than 5 minutes. And the reason why we choose that time is because most seizures end on their own in the 2 to 3 minute time frame and will abort spontaneously. But if they don't, then it's unlikely that they will be able to abort spontaneously. And that's a point where you would want to initiate treatment. The second time point that is found to be important is 30 minutes, which is beyond which seizures are likely to lead to long-term consequences. This comes from some studies or physiologic studies, which suggest that there could be more permanent brain injury due to cytotoxic type of changes or some ischemic changes that could occur with prolonged seizures. And so those 2 time points are very prominent in some of the discussions that we have and some of the protocols that are derived for management of status epilepticus. There's a specific definition for refractory status epilepticus. And refractory status epilepticus refers to continuous seizure activity, which is not controlled by first line and or second line anti-seizure medications. And so we'll talk about what those first and second line medications are. That's been thought of the definition of refractory status epilepticus. And super refractory status epilepticus refers to status epilepticus, which is not controlled by third line agents or essentially anesthetic agents, especially after 24 hours or longer of anesthesia. So as you wean anesthesia after managing for 24 hours, then if seizures recur, they're in super refractory status epilepticus. So this is just a different kind of depiction of the same timeframes. A patient has a seizure. As I said, it might self-abort within the 5-minute time frame. That T1 is the 5 minutes, after which you're having impending or early status epilepticus. After 10 minutes, more of an established status epilepticus. After 30 to 60 minutes, particularly if you've tried to manage things in the first 30 minutes and haven't been successful, then you enter a refractory status epilepticus phase. And then after 24 hours, this is super refractory status epilepticus phase. This is one of the treatment protocols that have been proposed, and it's in line with those different types of phases that we discussed. So in the first 5 minutes, we have a stabilization phase. In the first 20 minutes is the initial therapy phase. If those aren't helpful and they're in refractory status epilepticus, and then you're starting to get into the second and third therapy phases. And I'll highlight these a little bit more specifically as we go forward. There is evidence behind some of the different medications that are used, and there's a number of trials that have been done in the past to try to guide some of this as well. But of course, it's quite difficult to complete a lot of these trials, large part because as we particularly get into super refractory status epilepticus, the actual numbers for the trials become quite low, and you need to have a more of a distributed multi-center trials in order to do that, and they're quite difficult to complete. So in the first kind of seizure and stabilization phase, within the first kind of 5 minutes, then this is where you're probably intervening in either with EMS or in the emergency department or in an inpatient setting. You're just trying to stabilize the patient and make sure that you're covering the ABCs and completing a neurologic exam to look for any clear indication of what might be happening. And it's really making sure that everything is being assessed with respect to oxygenation, blood glucose levels, and trying to get some blood work, and just making sure that the patient is stabilized and seeing if it's going to spontaneously abort. After that, and then you get into the initial first-line therapy phase of management, and these essentially comprise of use of benzodiazepines. And the guidelines suggest either using intramuscular midazolam or intravenous lorazepam, or possibly intravenous diazepam. Part of this comes from the Rampart trial, which was an out-of-hospital management trial with EMS, looking at the difference between intramuscular midazolam administration versus intravenous lorazepam. And essentially, intravenous lorazepam worked faster when it was administered. However, it took longer to administer it, and so there was really no significant difference between those two groups, and it leads me to think that essentially whatever you have available to you in terms of a benzodiazepine is, from a practical point of view, is probably going to be what's most important. So sometimes we send patients home with rescue medications. And that might be rectal diazepam or buccal midazolam or intranasal or sublingual Ativan. And depending on where you are in the hospital, and I know here at London Health Sciences Centre, depending on where we are, we can only have access to certain things. So on the ward, without critical care support, we just have oral routes. In our epilepsy monitoring unit, we have buccal midazolam routes. In our emergency departments and with our critical care teams, then we do have more intravenous options. So depending on what you have available to you, that it might influence what you can use in the first line, but essentially trying to get benzodiazepines administered is the most important thing. And if you do have either one of the intramuscular or intravenous routes, then that would be most appropriate. After giving benzodiazepines, you're likely thinking about second-line therapies as well, and that usually is one of our anti-seizure medications that has an intravenous route. So there was a trial that looked at the ESET trial that looked at 3 different anticonvulsant medications for status epilepticus, looking at the difference between levetiracetam given at 60 milligrams per kilogram plus phenytoin or given at 20 milligrams per kilogram. Of course, here in Canada, we use more phenytoin, and then valproate at 40 milligrams per kilogram. And there was no significant difference between each of those. So again, depending on what you might have available to interestingly enough, when we try to prescribe levetiracetam in the emergency department or on the ward, before we had to send it to pharmacy, and the pharmacy team would make it up and bring it up to us. And oftentimes that might have been 30 minutes or 45 minutes later. And so it wasn't helpful in this kind of context. And so obviously, phenytoin is used all the time in the emergency department, in large part because it's easy to access, and they can be mixed really quickly, given in mini bags and administered very quickly. And so that's probably one of the reasons why it's such popular use. There has been some evidence suggesting that you can give direct push levetiracetam as a bolus, and so we've worked with our pharmacy to now mix a bolus dose into a small amount of solution and then give it over 15 minutes. So we've worked with our pharmacy to try to figure out how to do that, and now that's ward stock, which means that we can have more rapid access to that. And so we've been able to kind of work with the hospital here to be able to introduce that here. And now we have better access to a couple of different medications in an emergent situation. I think also you just want to know what you have available to you in your setting. So maybe some patients or some people might not have access to IV valproate, or some of these other medications, and also acknowledging that there are other intravenous medications such as IV phenobarbital, lacosamide, or berbeраcetam that could be used as well. I see that there's a hand up there.
Yeah, thanks, Derek. Can you even, we can't give phenytoin over less than about 2 hours. So when they talk about 60-minute resolution, is that 60-minute from just decide to treat the patient, or following giving a dose, which, as you mentioned, might be different depending on which of these drugs we choose?
Yeah, so probably following giving the dose is essentially what we'd be looking for, I think. And you might start to see then overlap of medications that you might be administering, especially if you're not seeing an early resolution of that. And as you know, practically going from first to second to third line and beyond, you know, sometimes we just don't wait for all of those timeframes to be done.
Thanks.
Okay, so to continue on, if we've failed, kind of as we've been talking about, failed giving the benzodiazepines, particularly with good doses, and failed our first line medications, then we would move on to kind of our third line therapy phases. And at that point, they would be considered to be in refractory status epilepticus. And unfortunately, there's no clear evidence to guide this phase, but oftentimes we do a combination of things. If we feel that the patient is still having either convulsive status epilepticus or have transitioned to a non-convulsive status epilepticus, then you would consider anesthetic doses of medications such as propofol or midazolam, and then consider using another of the second line therapies. So if you've given intravenous phenytoin, then you might end up giving intravenous levetiracetam or valproic acid as well. Now, usually by this time, patients are intubated and sedated with something like propofol or midazolam, something that we can wean and turn off quickly to reassess patients as well. And depending on what your availability is, and this has been a struggle for everywhere is getting access to timely EEG. If you do have access to timely EEG, then that would be really helpful to know if patients have converted into a non-convulsive status epilepticus if they haven't recovered the way that you would expect them to have recovered. And then if you have patients who are intubated, sedated into the intensive care unit, and you've kept them sedated over a period of 24 hours or overnight, and then you wean that sedation and they go back into having either convulsive or non-convulsive seizures, then they're into a super refractory status epilepticus. In which case the treatment strategies after that are, we try many different things, and all of it is not greatly, there's not a lot of great evidence behind all of the things that we try, but we end up trying a bunch of things all at once. We have to remember that one very simple concept of status epilepticus is that there's now an imbalance between inhibition and excitation, that usually inhibition can help stop or inhibitory processes in the brain can help stop seizures from continuing on too long and help them self-abort. But in these kind of cases, there's now an imbalance between ongoing excitation and a relative lack of inhibition. So that has failed. And over time, as we continue with ongoing seizures, we actually can see some changes that are occurring at the synaptic level, in which case we start to see involution and decrease in the expression of GABAergic receptors, whereas there's an upregulation of NMDA or glutamatergic receptors. So now it's almost like a feed-forward type of system where it's perpetuating itself. You've got more excitation, and that continues on with an even decreased inhibition. That may influence what you might think about using from a medication standpoint and a treatment strategy. And certainly it's influenced some of the thoughts around management of refractory and super refractory status epilepticus. Now, if you think about all of the different mechanisms of the medications that we use, we kind of can break them down into what's on the excitatory side of the system and what's on the inhibitory side of the system. And a lot of our treatment strategies early on are trying to increase the use of GABAergic or the inhibitory type of side of the system in order to help stop with the medications. We also use things, so you can see the SV2A modulators help try to reduce the excitation of the presynaptic excitatory cell, same with our sodium channel blockers. But we can also start thinking in terms of what is it that we can do from the postsynaptic excitatory receptors that might be able to reduce some of that excitation. So there's been a lot of interest in use of ketamine earlier on in the management of refractory status epilepticus. And from an infusion point of view and from an intermittent anti-seizure medication point of view, use of medications such as perampanel, which is also an AMPA receptor, which works on the glutamatergic excitatory side. And so there's some different ways of that you can use your knowledge and think about rational polypharmacy essentially, and trying to optimize what medications you try to use. Now, of course, as we all know, there's a lot of trial and error here, and in spite of knowing that there might be a reduction in GABAergic or GABA receptors, it's not that we don't use benzodiazepines. We still use benzodiazepines and barbiturates and propofol if we need to. But we just kind of also can think about it a little bit more and use some theory behind it too. There has been some newer definitions as well of prolonged super refractory status epilepticus. So these are patients where status epilepticus persists for more than 7 days with the use of anesthetic agents. And then prolonged refractory status epilepticus, where things persist for 7 days without the use of anesthetic agents. And so these longer term definitions have also been started to be used. Once we get into those longer terms, super refractory status epilepticus situations, then again, there is less studies that have been done on this because of how difficult it is to do work in this area. But certainly there is some evidence around some of the strategies that we'll use. So as we mentioned, there are some oral medications that we might try to use that we wouldn't use kind of first or second or third line, I guess. We think about inhalational anesthetics that have been used over the past and with thoughts about making a little bit of a resurgence. Brain surgery if needed. We have implemented ketogenic diets in the past, vagus nerve stimulators we've used. And so some of these strategies that we end up using, just trying to do anything that we can to stop seizures, particularly when they get into that really more permanent phase or the persistent phase. And so this is just a summary where we hope that seizures will self-abort early. We'll use benzodiazepines early on in the course of the management of status epilepticus with IV anti-seizure medications. And then if needed, using IV anesthetics plus more of the anti-seizure medications. And then if it's really prolonged, then we use maybe different anesthetics plus different or more anti-seizure medications, and then other strategies. And when I think about how we manage these patients, then I often will describe it to families as looking at three kind of blocks of treatment strategies. The first is the use of continuous infusion medications, and that's really just to control the seizures as they're happening in the moment. The others are the use of intermittent anti-seizure medications and other strategies, whether it be ketogenic diet or neuromodulation. Again, trying to prevent seizures from recurring once we're able to come off of the continuous infusions. And then, of course, we want to look for a targeted etiology where we can try to do more targeted therapy. So whether it's immune therapy, if we think that this is an autoimmune condition, whether it's on antimicrobials, if we think that it's an infectious condition, or if there's something structural and surgical resection is needed. So this is the kind of strategy. And just to depict that, we think of the first infusions as being just a blanket on a fire, just to try to put it out as quickly as we can. And then every day we try to lift that blanket and see if the fire starts up again or not. And then the other therapies are really meant to build a foundation, so eventually we can pull that blanket off and not need to reapply it. And essentially what we're hoping to do is get off the continuous infusions as quickly as we can. So we're trying to work as fast as we can to be able to remove those continuous infusions. And there are some times if you're dealing with patients on the ward or even in the ICU, that all you need to do is use anti-seizure medications. You may never need continuous infusions. But we certainly have had those patients who have needed continuous infusions for weeks and months. And so this ongoing strategy is something that we continue to use. This is just an example of one of our patients who was in our ICU for 180 days. And these are all the different medications that we tried over different timeframes, all the different infusions that we tried, including isoflurane, and then other strategies. This was a bit ago, so this is before we started using more of the ketogenic diet strategies, as well as the neuromodulation with the vagus nerve stimulation strategies as well. But just to give you an idea of how these things can evolve over time. And certainly this was at a time where we started using ketamine later than what we might use now. And I would say that just with isoflurane, it is making a bit of a resurgence in some discussions on refractory status epilepticus. We have used it in the past, and we've also published a series where we feel that there might be some more brain injury associated with the use of isoflurane than benefit. And so at least at that time, the way that it was being administered, then we were a bit reluctant to probably do that again, but we're waiting for some more data and see what other groups, what their experiences with some of the newer mechanisms of being able to administer isoflurane in the intensive care unit, for example. So when we take a look, what we just discussed about was the management of convulsive status epilepticus, but of course, there are many different types of status epilepticus. And I think it's important to recognize that it's not all the same. And you might not have to be as aggressive with some types of status epilepticus than you might with others. And so when we classify status epilepticus, we break it down into two big groups. One is with motor phenomena, and one is without motor phenomena. And the top panel here, the middle panel, really just kind of looks at what is status epilepticus with motor phenomena. So this is where we would see our convulsive status epilepticus and the emergency that we had just talked about. We can have some patients with myoclonic status epilepticus. Maybe the most prominent time that we would see that is after cardiac arrest, as was mentioned earlier. But we might also get focal motor seizures, and these patients may actually present to you completely conscious and completely able to kind of describe what their symptoms are, and you see that they have focal motor status epilepticus, which is also termed epilepsia partialis continua. And then you can have also non-convulsive, or sorry, status epilepticus without motor phenomena, which is also thought to be, or is known as non-convulsive status epilepticus. And we can break this down also either without coma. So these are patients that are going to be in the emergency department or on the ward, or you can have patients who are with coma and are more likely to be the ones that are more aggressively treated in the intensive care unit. So depending on how patients present, we need to kind of break down what type of status epilepticus they have, or what is the concern, and how aggressively do we treat patients. So just to kind of put it a different way, we have a continuum of risk of brain injury, where on one side, if we have certain features such as focal motor status or epilepsia partialis continua or absence status, then those actually don't have a high risk of brain injury. And we can actually manage them a little bit more conservatively. On the other end of the spectrum, we have convulsive status epilepticus, as we talked about, and that is the neurologic emergency that we have high risk of brain injury if we don't treat. Then in the middle, we have non-convulsive status epilepticus, and that could be without coma or with coma. And this is a confusing group for everyone. And whenever you go to a meeting, then it's always a really highly attended group meeting to see, what is the latest and how to treat some of this and what are the thoughts around it. This just kind of shows that T1 and T2 might change depending on what type of status epilepticus it is. So we talked about 5 minutes and 30 minutes for convulsive status epilepticus, but for example, focal motor seizures or focal motor status, that might be a different and more prolonged time frame. So you might not have to be as aggressive with them. When we, going back to this continuum then, we also want to make sure that we take into consideration EEG findings. And so with the EEG, particularly with the non-convulsive group, then we might find electrographic seizures. We may see electroclinical correlates of either seizures or status epilepticus or non-convulsive status. And then there's a whole group that you'll probably hear about and maybe using yourselves, which are called the ictal-interictal continuum. So these are a group of EEG findings that is still not completely clear if they represent a status epilepticus or not. This group of findings often have to do with periodic discharges or rhythmic discharges that we can see that can occur across the whole brain or be generalized, or could be focal, so in different parts of the brain. And depending on what the finding is, then we can see a difference in terms of association with seizures, and also a difference in association with mortality. So just to give an example, if a patient on their EEG shows what we call a generalized rhythmic delta activity, then it's felt that it's not really particularly associated with long-term risk of seizures, and it doesn't have a high mortality risk. So that might be something that we don't have to be as aggressive treating. However, if we see something with lateralized periodic discharges, then that has a high risk of having seizures associated with it. And if they're in bilateral independent periodic discharges, then that also has quite a high risk association with seizures, but also a high mortality risk. So all of these different things we can start to put into different contexts. With respect to what these are, what the features are, and how fast the features are, that also is dependent. That also kind of then predicts what is the seizure risk associated with it. And so, for example, if we have lateralized periodic discharges, regardless of the frequency of them, then they have a high seizure risk associated with them. But the faster the frequency, then the more likely they're going to be related to seizures. However, if we have generalized rhythmic delta activity, then regardless of the frequency of them, then it's thought to confer a relatively low seizure risk. So again, we can use EEG features to help us recognize how aggressive we need to be. These can be really challenging, not only EEG features, but also patients to manage, because then you're not sure, what to do with them in terms of a treatment strategy. And what this is a Salzburg criteria, which essentially helps us define when is it that we would say that they're in non-convulsive status epilepticus just versus possible non-convulsive, or whether they're not in non-convulsive status epilepticus. So if you have a clinical suspicion, but there are no epileptiform discharges and no concerning features, then they are not in non-convulsive status epilepticus. However, if you do have a clinical suspicion and there's clear epileptiform discharges that are faster than a certain frequency range, then they are automatically in non-convulsive status. However, in this in-between group, we can use other features to help us differentiate. And probably the biggest one is looking for, not only looking for subtle clinical features, so maybe some twitching, or something else that will provide an ictal phenomenon that we can correlate with the EEG changes, but probably the most one is the use of an IV anti-seizure medication, a good load of an anti-seizure medication. You can use things like benzodiazepines in this situation as well. And what you're looking for is an improvement in both the EEG and both clinically. So, but sometimes benzodiazepines cause a lot of sedation. So that might not be appropriate to use on the ward, or it might confound what your clinical outcomes might be of the trial. So you can use a non-sedating IV anti-seizure medication, such as the ones in our second line therapy, to see if that does both a clinical and EEG improvement. If it does, then it means that they were likely in non-convulsive status epilepticus, and then you would treat accordingly. But if it doesn't have any clinical change, then it's just still a possible non-convulsive status, and it might be more of an encephalopathic finding rather than something that's specifically related to seizures. So that means you would hunt and treat the underlying condition or abnormalities rather than being aggressive at treating the seizures themselves. So hopefully that's clear, and I'm happy to field questions about this later too. So how do we kind of manage all of this? Especially if you have someone who's on the ward and you wonder if they're in non-convulsive status epilepticus, you might trial something intravenously, an anti-seizure medication that is non-sedating, for example. And if that doesn't work, whether clinically, no clinical improvement or EEG improvement, then you can consider doing another one of those medication trials. And then you try to take a look, is there seizure cessation or minimal seizure burden? If yes, then you just continue to observe and try to maximize their medications. If no, then you try to see, are they in a coma, or is that seizure pattern causing decreased level of interaction? If it is, then you may consider, if appropriate, going, trying to use being more aggressive into the intensive care unit and using some of these medications to try to stop the seizure pattern if you're convinced that they're in non-convulsive status. If not, then you just might want to be able to optimize or maximize their enteral anti-seizure medications and try different ones and see if that helps. In which case, you wouldn't be as aggressive as treating them intubating them in the ICU. And so, these are very challenging cases. In large part, it depends on what the goals of the patient are, how sick they are, where are they on their trajectory of illness, and try to see would it be within their goals to be really aggressive or not, and then try to see what would be the best pathway forward, whether it's optimizing their oral anti-seizure medications or being aggressive and going forward with intravenous anesthetic drugs. It is really a risk-benefit analysis of trying to see how aggressive to be with some of these patients, particularly in non-convulsive status epilepticus patients, because our treatment also are not perfect, and they can cause morbidity and mortality as well. So there's an increase in mortality with use of intravenous anesthetic drugs in these patients. And whether that's a direct correlation or because of confounders, it's a matter of debate. But nevertheless, these are not benign medications. We know that there can be complications with prolonged anesthetic use, such as use of propofol, including propofol infusion syndrome, with use of midazolam, which can accumulate and cause prolonged sedation. Barbiturates can cause paralytic ileus and risk of infections as well. Ketamine can cause tachyarrhythmias, and inhalational anesthetics can cause increased risk of infection and paralytic ileus as well. There's complications of our anti-seizure medications that we use, and we know many of them quite well, whether it's valproic acid or levetiracetam, when to use patients, which medications to use in patients with hepatic dysfunction or renal dysfunction, sometimes causing arrhythmias such as lacosamide in IV formulations to monitor, or phenytoin, phosphanytoin with hypotension and bradycardia. And also, we just know that prolonged intensive care can cause complications in and of itself. So we have patients who have had abdominal complications with paralytic ileus, with hepatomegaly, recurrent infections and sepsis, pulmonary complications, venous thromboembolisms, and critical illness neuromyopathy. So they have all of these complications with prolonged intensive care. But on the other side, having status epilepticus and very prolonged status epilepticus can itself cause many complications, including catecholamine surges and cardiac complications. So it is certainly a challenge. And really, many of these patients, if they're really prolonged, will end up having long-term epilepsy as well. So many of our patients who have had a prolonged status epilepticus will eventually need to come back into our epilepsy monitoring unit, be assessed, and we have had a number of patients who have required temporal lobectomies because of changes in their hippocampus and new mesotemporal epilepsy as well. So hopefully I gave you a little bit of an overview, both in the emergent management of convulsive status epilepticus, but also just some insight into how to think about non-convulsive status epilepticus. I know it can be very confusing and challenging, so I'm happy to have a discussion about that as well. But when you would use continuous infusions, how that is used in the context of intermittent or other therapy strategies, and then of course always thinking about targeting the underlying etiology of it all. And then, there's been a fair amount of recent work into how do we follow up these patients in outpatient clinic, and there's been a little bit of a consortium and a formalized group that are looking at setting up a post-symptomatic seizure clinic where they can do EEGs and do clinical follow-up routinely for patients that are seen in the hospital or in the ICU setting. Because many patients go home on anti-seizure medications. Sometimes they don't need to do that if it's thought to be a provoked seizure in the hospital, and that they were, managed, they recovered, but they are sent home with anti-seizure medication. So it's important to re-evaluate what the clinical course is after discharge, maybe reassessing with an EEG or imaging if appropriate, and then determining what is the risk of long-term epilepsy if they need long-term management with medications. And of course, all of this has social implications as well with respect to them in their community and with their families, and what impact do anti-seizure medications or the risk of having seizures have on work and driving. So those are always things that we tend to follow up with. Our clinic, we do have a clinic to do that. It's not a formalized clinic. We just do it in our own outpatient clinics, but we try to identify which patients have been started on anti-seizure medications with symptomatic or new onset seizures in the hospital and then follow them up. Of course, if they're already established patients with epilepsy, then they would go back to their epileptologists or their treating physicians to make sure that they're back on a good strategy for a long-term management of their epilepsy. So I think I'll stop there and be happy to have a discussion with if there's any questions.
Derek, I'll maybe ask you a bit about using ketogenic diet. So like when in your guys' experience, like when do you start sort of thinking about that? And I mean, how often, I guess, do you use it? Is there like a typical scenario?
Yeah, it's a great question. I think that one of the things that we've been able to establish over the last few years, I would say, as you know, as we don't manage a lot of the really complex, they don't come along that often. But when we do manage, we've started to have a workflow of that. So there needs to be a lot of forethought as we get into the thought of using ketogenic diet in the ICU, and it has to have a lot of buy-in from a number of different groups. So we have a dietitian in our ICU, which is really good at being able to identify, you know, how to get the ketogenic diet for their feeds. Working with our pharmacist to make sure that there isn't any medications that are being delivered in dextrose or anything like that, which can then affect the ketogenic diet, but also just in our own management. So we want to make sure that as soon as we identify someone who we think that might be having in that really prolonged super refractory status epilepticus, so more than 7 days, if we're identifying that this might be that type of patients, we're starting to get them off of things like propofol right away. And transitioning to other type of medications such as ketamine, for example. You don't want to have propofol in that context. We try to get them off of any barbiturates, any that might have been started, valproic acid, anything that might be then contraindicated in the use with ketogenic diet. So we're already starting to transition that early on in their course, so that our goal is to probably start them within the first week or so. So it does take a lot of coordinating with the teams in order to do that. And of course, we send off a metabolic panel just to make sure that there's nothing from a metabolic point of view to contraindicate our use of the ketogenic diet. That being said, it's very challenging. We've started it on a probably, I would think, you know, a handful of patients. Not everyone is completely appropriate, or by the time we think that we're going to need to use it, we've started to get better control of their seizures. And the other thing that we watch very closely are liver enzymes, and we've had to stop before because of rapidly increasing liver enzymes. So it has been a challenge when we have used it. It's not straightforward.
And have you had some outcomes where you thought that it was helpful in?
Yeah, this is the, you know, at that point in time, you know, as we're kind of getting ready to start a ketogenic diet, we're also talking with our neurosurgeons about implanting vagus nerve stimulator. We've tried a bunch of different medications. They may have been given IVIG and some steroids. And so, you know, it's really kind of everything comes together. And if all of a sudden seizures start to abate, or we get on top of the seizures, then we're really not sure which of anything, you know, has worked. So that's very difficult to tease out if it's been helpful.
I think Marty's got a question.
Sure.
Derek, you brought up continuous EEG, and you know it's a major resource restriction. I mean, as far as I'm aware, it's not available in the GTA. And before you say Toronto Western, I'll say they don't have it on the weekends. So does it really feel like it's a continuous option? What surrogates, or I guess beyond that, if you're using time-limited intermittent EEG, I've heard of the Cerebell or limited montage that we can run sort of 2 and 4 lead EEG. What should a system like ours be looking for that way if we're not going to have you know, epileptologist in a box 24/7? Yeah,
that's a great question. And, you know, I think the ACNS was quite careful in their wording of the indications for CEG and their recommendations, just acknowledging that not all centers have access to continuous EEG monitoring. So it's a huge challenge. You know, what we do here is we have what we call a sub-hairline montage. It's hooked up to our bedside monitoring system. It's not an ideal system, but it helps us be able to at least get an idea of what is the state of sedation And if there's symmetry or asymmetry across the left and right, we have basically frontal channels and temporal channels. And so we can see if someone is in burst suppression, for example, and it helps the fellows and the ICU staff be able to kind of get patients down to a certain kind of level that they're able to interpret and able to use. Prone to artifacts, so sometimes there's a lot of overcalls, especially in the middle of the night, of people thinking that there's seizures when it's just some muscle activity. But it is a good screening tool to be able to use. So luckily, we do have access to continuous EEG, and I'm one of the ones who read it, including on the weekends, so it can be done. So we do kind of read those continuous EEGs. Scarborough is obviously, I think that there's some trialing of that in Canada. We're not a site for that at the moment, but that would be something that might be a good idea to have, to follow through with something like that, where you can have satellite centers to a hub or something like that. My hope, and I've been thinking about this a lot, is whether we can try to have outside hospitals have access to some type of EEG net or something that they could put on, and that we could read it centrally and provide that service and that way we might even be able to prevent some need to transport patients to different centers if needed. So that's a hope. That's takes a lot in terms of infrastructure and making sure that we have privacy and databases that are compatible and all of that. But it's something that I hope is going to be possible at some point in time. Because I think, but as of right now, if you have intermittent EEGs, that's going to be your best thing. If you can have them for a little bit more prolonged time, then you can use things like the 2 helps 2B score to be able to identify. So for example, if your first EEG can be an hour, for example, then you might be able to then identify, are there any patterns here that are going to predict the patient to have ongoing seizures? And is this a patient that really needs continuous EEG monitoring? And that might help you advocate for transport if needed, or maybe coming up with a different solution.
That's great. We're a couple of minutes past 1, but thank you so much for spending your time with us today and giving us a lot to think about. I think for all, the sort of frontline staff dealing with seizures when they usually start, and us that come in sort of later on and try to sort out how to direct things in the longer term. It's a lot, I think, to think about and a lot of discussions to take away. Marty, we can keep talking. Thank you so much, Derek, for joining us today. I just really want to express my appreciation.
Yeah, no, really happy to do that, and I recognize that it's there's so much more to talk about than what you can do in an hour session. So if there's anyone there that would like to have more discussions, I'm more than happy to do that offline as well.
Thanks. Take care.
All right. Bye.